Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. The patient in this procedure attended reporting a fully blocked left ear. So this is the patient's left ear that we're starting with. They did also have some earwax in the right ear, but the left ear was the most blocked. This earwax is extending right from the entrance of the ear canal all the way to the eardrum, so approximately 2.5 up to 3 centimeters in length. So the technique we use in the left ear is we use the suction probe. So the suction probe, the zonal suction probe, to elevate the posterior concha cartilage. So at the entrance of the ear canal, you've got this cartilage. You can see I'm lifting that up using the suction probe. So it's almost like a crowbar effect. I'm lifting that up, creating space, which I can then enter with the endoscope. It's a bit of a tricky technique. When we train clear wax delegates, they do need a bit of practice, but once they get it, it kind of, it's almost like that eureka moment. Oh, that's so easy. Sometimes though, with the left ear in particular, both ear canal entrances can collapse, which actually causes the ear canal to be completely shut. It's a slightly different technique we have to deploy for that, but this is the most common technique. For most ears, that's how we enter the left ear. So you're going to see it again. I'm lifting the cartilage up with the suction probe and then entering in with the endoscope to get the view. And whenever you remove earwax, if the ear canal is fully occluding, there's always a blind spot. So if you can always rewind to this one, but at the beginning of the procedure, you probably saw that in the left ear to the right near the entrance, there's a bit of a blind spot there. And if you can loosen that wax off the canal wall in the blind spot, it just helps with the rest of the procedure. This earwax was quite satisfying to remove. It just came out in nice large chunks. It wasn't mushy, it was a bit dry. It was a bit impacted medially, so we're in the medial part of the ear canal now, so near the eardrum. It was a bit more densely compacted, so a bit more tricky. And whenever we work near the eardrum, of course, we've got to be careful, gentle. We've got to be gentle and careful no matter where we are in the ear canal, but more so when we're working this deep. So I'm just pulling down, should I say, the wax off the roof of the ear canal to loosen it. And the patient's got some wax here that's lodged in the inferior recess, which is a little trench at the base of the eardrum, and also the anterior recess, which is a little ridge to the left of the ear canal wall. You can see the anterior recess there. There's a bit of dry skin, bit of wax. It wasn't important. If I'm going to try and remove that, it's just not significant, guys. I know some people really like watching the ear spotless, but it's just magnified dry skin and wax. And for removing every little last speck, especially in that region of the ear canal, the medial bony part, you're going to cause trauma. And the patient can elicit the gag reflex, and he did actually have the gag reflex in the right ear. So that's a cough reflex. At the base of the ear canal, you have the vagus nerve, and a branch of the vagus nerve is called the Arnold's nerve, and we stimulate that by putting pressure against the base of the ear canal. It stimulates that Arnold's nerve and it elicits a cough reflex. We don't want the patient coughing during the procedure, especially during these times. So just in the right ear, so the technique here, we enter first with the endoscope. It's a slightly different technique to the left ear. We enter the ear canal with the endoscope first, and just as we enter the ear past the first bend, we then stretch the ear canal cartilage, the posterior concha cartilage. So the posterior means the back part of the ear canal. Concha is near, kind of like the cartilage near the entrance. We push it to the left and we open up the ear canal, we stretch it. You can see I'm going in, I'm putting it to the left. By opening up the ear, it allows me then to insert the suction probe. And you're probably wondering why I'm being a bit technical in this video. When we were training the clear wax delegates, we had a couple of training courses last week and the week before, and I've got a couple coming up in the next week and in early May. I think the videos can be a great learning tool as well for the delegates or someone who's interested in coming into the course. It just explains it a bit better. And some of the delegates did say, are you able to explain it during the videos as well? So they can always refer back to it later. So sorry if you found that a bit boring, but just wanted to educate some of the prospective clear wax delegates or those that come in the course. So again, we've cleared the wax, the occlusion's gone. You can see a lovely healthy eardrum there. You've got the light reflex. There was a bit of debris around the edge, and Because when the cartilage portion, I was just trying to see if I can remove it. So this is on the posterior canal wall near the entrance, so it's quite lateral, a bit of dry wax, skin, just lifting it off. Patient was fine here. Bit of dead cavement at the base, a bit of clarinetting there, I think. So clarinetting is when the skin violently flaps, so I just left that alone. I'm not sure if I went back for that. Bit more wax. Now in both ears the wax was quite dark, it was oxidised, it's been there for a while. Just a bit of speckle wax there, just gently hovering over. I always, when I perform procedures, I always remember that game Operation, where if you make contact with the sides, I think the nose goes red and it makes a beeping sound. So we always want to avoid contact, especially in the bony part, the inner 2/3 of the ear canal. The outer third, where we are now, we can put a bit more pressure on because it's cartilaginous. But that can also then elicit the gag reflex, the cough reflex. So just some dry skin laterally near the entrance on the anterior canal wall, so to the front part of the ear canal, which in the case of the right ear is the right side of the ear canal. There's the patient's eardrum, and I think I stopped at that stage because the patient was coughing a bit. See the wax, it's really, really dark. Now it's a lot of wax, it's a huge extraction, but actually when I weighed it, it was quite light. So you saw my video yesterday, it weighed in over 1 gram. This one is only 1/3 of a gram, but there was a large quantity of wax. So that just goes to show that the wax can also be densely packed, and so you can get equal amount of wax in one patient's ear and another patient's ear, and you put them side by side. In terms of quantity, they're the equivalent, but when you weigh them, you can get differences in weight. So wax from people from ear to ear can change in density. I hope you enjoyed that video, guys, and you're all having a lovely weekend, and I shall speak to you soon.